Good afternoon. Welcome to World Forum for Women in Science. We are in the technical session, which is named Health, and I would like to give the words to our moderator for today. Yes, Professor Smita Power, maybe you would like to moderate the session and announce the first speaker.
Good evening, everyone.
Good evening.
Am I audible?
Yes.
Yeah. Good evening to all the participants, and I welcome you all to this Women's Forum on Science today. And I'm the moderator. This is Professor Smita Pawar from Osmania University, Hyderabad, India. And I would like to introduce the first speaker, that is Anita Butel. I think she's already joined us. She's a PhD in physiotherapy at the University of Cape Town. Anita Butel is a South African physiotherapist, currently completing a PhD in physiotherapy with focus on breast cancer rehabilitation. I think she's going to talk on the topic and investigation of an education and exercise self-management intervention for the breast cancer survivors. So with this brief note, I would like to invite Anita Butel to present a talk.
Hello, thank you, Professor Pawar. I'm just starting my presentation. 1 second. You can see my screen, right?
Yes.
Thank you for the opportunity to share my research.
Yes, we are able to hear you.
Can you hear me?
Yes.
Okay. Thank you for the opportunity to share my research. This project included a series of sequential studies, of which I'll provide an overview and highlight some key results. The title of the project is An Investigation of the Rehabilitation Needs, Development and Preliminary Outcomes of a Self-Management Intervention for Breast Cancer Survivors. The background to this project was that breast cancer is the most common cancer in women worldwide. 12% of women will be diagnosed in their lifetime. Survivors of breast cancer form the largest group of cancer survivors in the world. In developing countries, the incidence is increasing. In Africa, incidence is expected to double by 2050. Medical cancer treatment causes long-term side effects for 10 years or more in breast cancer survivors. Commonly occurring physical long-term side effects include persistent upper quadrant pain, cancer-related fatigue, weight gain, lymphedema, and impaired physical function. In 2021, the World Health Organization launched the Breast Cancer Initiative. This aims to support those affected by this global health challenge through 3 main pillars, namely health promotion, timely diagnosis, and treatment and supportive care. This project addresses supportive care following the completion of primary medical cancer treatment, including surgery, chemotherapy, and radiation. The problem statement for my project included that rehabilitation interventions, including exercise, can reverse or significantly improve long-term side effects. However, the evidence is based on resource-intensive interventions developed for high-income settings. In developing countries, breast cancer rehabilitation has not been prioritized. The experience of long-term side effects and their rehabilitation needs were unknown in South African breast cancer survivors. Therefore, the purpose of my research was to investigate the lived experience of long-term side effects in South African breast cancer survivors from a low socioeconomic background and their rehabilitation needs. Then to explore the effectiveness of self-management interventions, including exercise, in early-stage post-treatment breast cancer survivors. and then finally to develop and evaluate an appropriate, acceptable self-management intervention requiring few resources to implement for South African women with breast cancer. The methods included firstly a qualitative study. We conducted focus group discussions with breast cancer survivors in the Southern Cape province of South Africa, and this study had a qualitative descriptive design. Next, we conducted a systematic review and a meta-analysis of self-management interventions, including exercise and requiring minimal clinical visits in post-treatment breast cancer survivors. Then, informed by step 1 and 2, we developed a 12-week intervention using published guidelines. A pilot evaluation was conducted of feasibility, safety, and preliminary outcomes using mixed methods. Some results of the qualitative study. 23 women participated. 5 focus group discussions were conducted until data saturation was reached. Women were between 6 months and 5 years following the completion of primary medical cancer treatment using the public health system in South Africa. 3 main themes were identified from the data using thematic analysis. Firstly, the long-term side effects were unaddressed and impaired the quality of life of survivors. They complained of persistent upper limb problems. Fatigue was perceived as an untamable enemy. They were surprised about weight gain when they expected to lose weight from cancer, and their physical function had deteriorated since their breast cancer diagnosis. They perceived a lack of information and access to support. They felt unequipped to self-manage their long-term side effects and survivorship concerns. They felt disconnected from support organizations, and they felt that they lacked knowledge about breast cancer, which would give them power. The third theme was that exercise was generally good, but neglected. Women in this study lacked knowledge regarding the specific benefits of exercise for breast cancer survivors. Exercise perspectives, preferences varied widely across the participants in our study. Facilitators and barriers for regular activity were identified. Some key quotations relating to the themes identified. Relating to long-term side effects. I still have this pain that's been there all along. The doctor always said it's probably from the radiation or from the chemo. And before the cancer, I could do a lot of things in one day. Now it feels like I can't go through half the work I did then. Regarding lack of information, nothing was said until it happened. The lymphedema started, and then I went to physio, but by then I'd already got it. What must be included in rehabilitation? All the stuff that I heard now that you guys went through, and I still have to go through, and I thought I was done. If I had this info, I would have been prepared. Regarding exercise, most of us still walk to work. We don't have transport or anything where we live. Indeed, in this province, many patients live more than 100 kilometers away from the breast clinic that serves them. Transport was perceived as a luxury, and this inspired us to explore the design of an intervention that did not require face-to-face clinical visits. So the intervention development was guided by the Medical Research Council guidelines for the development of complex interventions. They provide a checklist of actions to consider. It was based on the social cognitive theory, and constructs included self-efficacy, outcome expectations, self-control, and behavioral capability, and also on self-management principles. These included goal setting, problem solving, action planning, decision-making, and resource use. It was informed by the qualitative study and by the systematic review results. Its content validity was established through a team of 5 local multidisciplinary breast cancer experts. These included an oncologist, a medical doctor who was also a breast cancer survivor, a physiotherapist, a dietitian, and a psychologist. Acceptability was evaluated and subsequently adapted through a small qualitative study. Prior to participation in the intervention, a pre-exercise screening was conducted to ensure that it was safe to participate in unsupervised exercise. This is a summary of the intervention themes by week. The intervention entailed receiving a printed handbook and weekly content and reminders through email, WhatsApp, or SMS for 12 weeks. Weekly activities and action planning were included. Participants confirmed receipt and participation in the weekly activities via WhatsApp, email, or SMS, whichever they preferred. Participants were offered the option of joining a WhatsApp group with other survivors to facilitate forming partnerships and social support. Themes included areas of need identified in the qualitative study, including general and shoulder exercise routines, specifically for breast cancer survivors after completing medical treatment. Information on cancer recurrence was included. Participants of the qualitative study requested this, as breast cancer is often diagnosed late in this country. Some key results of the intervention study: 33 breast cancer survivors were included. Their mean age was 55 years old, and they were from throughout South Africa. A pre-test, post-test study was conducted, as no alternative intervention existed, which could have been used as a control, and also to avoid a delay in the provision of information about their disease to participants. The intervention was feasible based on ease of recruitment, data collection, and intervention delivery. Retention was 94%, and costs per participant were about $30 US. The intervention seemed safe to deliver in this study, and patient-reported outcomes that showed significant improvements in pain prevalence, severity, and interference, fatigue prevalence, severity, and interference, exercise participation, health-related quality of life, and self-efficacy. Limitations and recommendations were many. Some were that the qualitative study results may not be generalizable, as the study was conducted in a single setting. There's a need for qualitative and epidemiological studies of long-term side effects and survivorship concerns in both urban and rural areas to improve understanding of rehabilitation needs. A variety of innovative interventions able to reach survivors, regardless of their geographical location or socioeconomic backgrounds, are needed to suit individual preferences. It was not possible in this study to obtain robust measures of adherence to the intervention due to the distance-based format. Future studies should conduct randomized controlled trials to establish effectiveness of the intervention, and psychological outcomes should be evaluated and addressed. The conclusions are that long-term side effects are a significant burden for breast cancer survivors after treatment. Current standard of care does not provide women with education, skills, and support to manage survivorship. The meta-analysis revealed that self-management interventions, including exercise, are effective to address this burden, requiring few resources to implement. And the results of this research are preliminary, however. Long-term side effects should not remain unaddressed, even in low-resource settings. Thank you.
Thank you, Anita. That was a very interesting talk. I have one question.
Yes.
So this is more about interventions towards the breast cancer patient survivors. So are you trying to do anything before the incidence of the disease itself? So are there any programs that you would conduct or are conducting for, first of all, preventing breast cancer?
I'm not sure. I haven't looked into that. I'm hoping that there would be breast cancer prevention programs active in South Africa. It's a good question, but I'm unfortunately unable to answer that.
Thank you. So any other persons who would like to ask a question to Dr. Anita?
I would like to ask about the lack of information. So how did you manage or deal with that with the patients? So how did the patients deal with it?
So the lack of information was identified in the qualitative study, and the participants, there was just not enough time in this talk to address all of them, but the participants did let us know what they wanted the information about. And then we tried to include that information in the intervention as topics.
Thank you very much.
So if there are no any other further questions, can we go ahead with the next speaker?
Sure. If we have some more questions, we can also discuss them at the end with question and answer section.
Okay. So I would just like to know if Dr. Mary Amoka is with us. She had message saying that she has a problem in connecting and she's trying to connect through phone. So Mary, are you around?
Yes, I am around, but I don't know how I'm going to share my I don't know how I'm going to share with my internet. So I think presenter can go while I try to fix the internet. I changed location in my house, so maybe after the next.
Fine then. So we'll proceed to the next talk till Mary fixes her problem. So the next speaker is myself. Though Dr. Mary Amoka is my co-moderator in this session, I think I have to do this job of self-introduction here. So this is Professor Smita Pawar. I'm a professor in genetics and biotechnology from Osmania University. It's a state university from India, the south of India. And I'm basically a cancer biologist, and I work extensively on cervical cancer. And also along with that, trying to come up with endogenous inhibitors, which would avoid drug resistance. So you can say that I work towards alternative therapy kind of a thing where the drug resistance is not being induced or elicited. Other than that, I think if you have gone through my profile, I hold various other positions like a director for Malviya Mission Teacher Training Center, which is basically a teacher training center for all over India. So we conduct various training programs for the teachers for regular upgradation. So that is a brief note about myself, and then let me share my screen first. I think, Mary, you have to stop sharing your screen, then only I can go ahead.
It was me. I was sharing the program. Now
okay. So now I can go?
Let's try. Yes.
Yeah. Are you able to see my screen?
We don't see it yet. Yes, now it works.
Now? Are you able to see my slides?
It's
right?
Not yet. Maybe just yes. Now, yes. Yes.
Can you have a confirmation so that I can go ahead?
Yes, you can start showing the slides.
Yeah, right. So the topic of my today's talk is upon andrographylite. It's a plant-derived multi-target inhibitor. pathway and its impact on this patterns. Before I go to the next, before the talk, this focus is Sustainable Development Goals in the 2015. And by 2030, all people enjoy. When it comes to the health issues, it tries to ensure healthy lives and promote well-being for all ages. Especially one of the goals, you can say the goal 3, you have the non-communicable diseases. By 2030, the goal is to reduce it to half. Just sorry for this mistake there. And then medicines and vaccines for both communicable and non-communicable diseases also figure out in this goal. So coming to this cervical cancer, here I would like to portray the incidence rate in India. If you look at it, you have the cervical cancer, which is going to overcome, or rather it will shortly overcome breast cancer, as the number of cases are increasing every year. So a brief about how does it progress. Here you have a graphical representation about from normal to LSIL stage, HSIL stage, and then finally to the cancer stage. And this is the intermediate stage where from HSIL, if it is detected early on, we can reverse it back to the LSIL stage. So the whole idea about this, can we really catch them early on? And if we are able to catch them early on, what is the kind of particular slide, which are like the druggable target cervical cancer, by using one single drug that is a plant-derived compound and making sure that there is no immune response, or rather a drug resistance that is being initiated by this. Because if you look at cisplatin, that's the most common drug that has been used for treatment of cervical cancer and is associated with cervical cancer, cisplatin-induced drug resistance. So after a point, it does not really have any impact on the patient who are undergoing treatment with cisplatin. So the whole idea of the study is how to overcome this drug resistance. So we have identified the main genes that are involved are the cancer-causing genes, the PI3K, the NF-kappa B, the COX-2, and the P10. So these are the 4 essential genes that we are targeting in this study. And if you look at the global scenario with the GPA datasets and the TGCA datasets, these have elevated expression. But if you look at the P10, which is a tumor suppressor, which is relatively low in expression when compared to the other genes. So basically what we are targeting here is to lower the expression of the target genes like the PI3K, NF-kappa B, and COX-2, which are the oncogenes, and try to enhance the expression of the tumor suppressor, that is the P10 molecule. So this is the immunohistological analysis of the tissues which we have collected from the patient samples. You have a stage 2 and a stage 3. So look at the any staining in this normal but moderately positive in the stage 2, and at the stage 3 it is strongly positive. NF-kappa B, same thing. In the normal, it is mild positive. But if you look at the stage 2, it is moderate to strong. And then at the stage 3 level, you have a very strong positivity that you find for NF-kappa B, that tells that the expression of PI3K, NF-kappa B, as well as the COX-2 are increasing gradually stage-wise. And if you look at P10, basically there is no staining, and then no staining in stage 3. So here we can include is to summarize the PI3K gene expression is relatively overexpressed. NF-kappa B is highly overexpressed, so as the COX-2. But the P10 levels, if you look at, the P10 levels are highly suppressed in the tumors, whereas in the normal tissue, it's relatively that is an it is hypotonic, it is antimalarial, a cardiovascular activity, antidepressant. So all these activity is happening, but not much of research has been done on cancer. So andrographite is bi-andrographite, and it is also used in the Chinese. It is anti-inflammatory, and it is used in treatment of the bacterial infections, diarrhea, rheumatoid arthritis, and other inflammatory diseases. Generally, the leaf and stem might work by stimulating the immune system. It may also prevent the flu for the viruses and then prevent the viruses from binding to the cells in the body. So they are also using for common cold, osteoarthritis, infection of the throat and the nose. So this is, we have done some initial molecular docking studies with doc, the NF-kappa B COX-2 as well as the P3K, which encouraged us to go further with testing of it on this lines. So we started testing of andrographite cancerous cells. We started with the HeLa cells, which are, the HPV positive cells so here you can see as the concentration is increasing, also cancerous cell line, even that the IC50 value we obtained was 6. Are you with me? Are you able to hear me?
But the internet connection might be quite.
I need someone to respond. Okay. Am I with you right now?
We hear you, but we don't hear you all the time.
Okay. I think I'm also facing the same problem here. But are you able to see my slide?
We are able to see the slides, but we are not able to catch every word.
Yes?
Yes, we see the slides.
Okay. And now is it okay? Yeah. Can I go? Can I proceed?
Yes.
Yeah. So here you can see the effect of andrographite on HeLa cells, CH cells, but with very high concentration, telling us that they are not lethal to the normal cells, but they are affecting only the cancerous cells that we have already proven here. We have done furthermore assays to establish the same fact, wherein we have done a transwell migration assay, where we have treated the HeLa with 5 and 10 micromolar concentrations of the andrographite. And if you look at the figures here, you find gradually the migration rate has gone down, both in HeLa cells as well as CH cells. So saying us that this molecule is able to prevent the cancer cell from migrating, which is one of the, as a cancer biologist, I think some of you all will be knowing that the cancer cell has to travel and migrate to spread. So if you are able to inhibit that activity, we will be able to control the cancer. So here it has shown us very good results. Likewise, we have done this matricial invasion assay, where we have treated with the same concentration, that is 5 micromolar and 10 micromolar. And as you see, we have the invasion also, which has been gradually reduced. If you look at the number of cells that has invaded, you can see in the figures that very few cells after the treatment are able to invade. Then further, we have done some, the IHC studies, the Western blots. And the Western blots have clearly shown, if you look at the effect of andrographite on this molecule, especially the PI3K, in the control, you can find a very big band, but as you increase the concentration, it is gradually reduced in the first, and you can look at the levels that it has gradually reduced to. So this shows that it is effectively inhibiting PI3K and AKT. Further, we have tested the other molecules. the NF-kappa B, COX, and P10. If you look at the P10 expression, which is a tumor suppressor gene, gradually we find an increase in the level of the P10, which is very clearly evident with the Western blots. So here you can see that these P10 levels have increased, but the NF-kappa B and the COX-2 levels have gradually decreased. So this is having an impact not only on one, but it's a multi-targeting molecule. Further, we have tested some of the apoptotic markers where we have seen an increased expression of the BAX levels and the BCL levels are going down. And if you look at the CIHA cells, the same results we have got, the increased level of expression of BAX and the BCL is going down. Further, we have done the immunofluorescence of the NF-kappa B protein in the andrographlite treated HeLa cells. If you look at the cells here, the andro-treated HeLa cells were captured for NF-kappa B, that is the green color. The first column is the panel, nuclear staining. Second column in the panel and the merged of NF-kappa B and the nucleus. And in the third column of the panel, these are the untreated cells showing the NF-kappa B overexpression. So these results induced tumor this finally, once they've developed to a certain stage, we have removed the tumors and we have looked at the inhibition of the tumor growth by the andrograph in the C57BL6. And the average body weight of the cat, the control, if the mice is not being treated with andrographlite, the size of the tumor will be very big. But as you're increasing the concentrations of the compound, you can see the gradual reduction in the size of the tumor. So we have proven it both in vitro as well as in vivo that this molecule is highly potent. And the same further, we have reconfirmed it by doing an IHC with the animal tissue. So this is an animal tissue IHC where we have looked at the PI3K after the treatment. So it is a strong positivity in the first stage, but when you start treating it, gradually at 30 mg, you do not find much of positivity here. Same thing with NF-kappa B, you can see the gradual reduction. COX-2 also goes down. And finally, in the P10 molecule, you can see that from no expression to we have a moderate expression. So it's a very positive result that we are getting here, that the tumor suppressor genes are getting overexpressed. Are you people still with me?
Yes.
Yeah. Further, as I've spoken to you about cisplatin, cisplatin is the only drug that has been given, especially here in India. It's a major drug that has been given for the treatment of cervical cancer, but this is leading to development of resistance. So to mimic the same thing, we have started treating the HeLa cells with increasing the concentrations of the cisplatin, which here I represent as CDDP. That is nothing but cisplatin, and gradually we have developed a cisplatin resistant cell line, which is able to take increasing dose of cisplatin. Cisplatin is a resistant cell line. Then we have done a clonogenic assay to show the effect of andro and CDP treatment on the cisplatin resistant cell line. So now what we have done is we have taken the controls. Then these are the cisplatin resistant cells. Then these are only andrographlite treated cells. And this is a cisplatin and andrographlite combination drug that we have tried on. And this combination works much better than the cisplatin in alone. So further, we have done certain assays on the cisplatin resistant HeLa cells. The resistant cells were treated for 24 combination of andrographite with 15 micromolar, host and PI, the untreated cells were used as the control, and the normal cell nucleus was visualized, and the cells undergoing necrosis were stained. So cells were imaged under an inverted microscope. If you see that the combination of cisplatin and the andrographite has given us much better results. It is inducing apoptosis at a higher rate when compared to cisplatin alone. So if you look at the images, here we can see that a combination drug of cisplatin plus andrographite will give us a better results. And further, we have confirmed the same with the migration assay, where we see that the cisplatin and andrographite is in together is able to inhibit the migration of the cells better than the cisplatin. Further, the matrigel assays also show that the combination of cisplatin along with andrographite is giving a better results rather than independently if we are adding them to the cells. And further, we have tested for what kind of effect does this combination have on various other markers like SPP1 for elucidate a combination. So the combination is always working better, and the P10 expression is gradually increased in the combination. Further, the same results what we had done earlier with the PI3K, AKT, and we have tested them. The control, when you take andro individually or you take both of them in combination, again, if you look at the individual cisplatin drug, when added, it is not showing that much of effect. But when you take it in a combination, the effect is much greater. So it is effectively inhibiting. Causes also the apoptotic marker as increase. So this study, in conclusion, I would like to conclude. This is the first slide that I said I will come back to later. So here, the andrographite is having a combination of effect by targeting multiple targets like COP3K, inhibiting NF-kappa B, but it is also inducing the impact, or it is also having an impact on the apoptosis pathway. And then the slides summarizes the whole study that we have done here. So it's a plant-derived molecule which is showing a lot of benefits. And one big thing is this patient need not suffer. The doses of the drug that is being given to the patients can be greatly reduced if we use this combination. So this is what we at this lab are working on. These are all my students. Majorly, you can find this work is basically my PhD students' work. If you can see here, this is Akbar Pasha and all the others from the lab. And we have got the funding from DST and SERB for this project. And I'll be very happy to take some questions.
Thank you. Do we have questions, or should we move to another speaker?
That's up to the participants. If there are no questions, then can we go ahead with the next?
Yes.
You are?
Sorry, can you say it again, maybe?
Is Dr. Mary Amuka ready with the slides?
We don't hear you, Dr. Sorry.
Sorry, my mic was muted. My mic was muted. Yes, please, I can try. I can try and see what happens. Yeah, I can try and see what happens.
So Mary, are you going ahead with this? Yeah, I think now we can see her.
Yes.
So let me introduce Dr. Mary Amoka. She's a lecturer at Roma University of Science and Technology. I hope I got it right.
Yes,
Mary is a lecturer and a registered dietitian at Department of Biochemistry and Biotechnology. That is at Kwame Nkrumah University of Science and Technology in Ghana. At the same university courses, she teaches courses which include metabolism and health and diseases, nutrition throughout the human life cycle, and nutrition in energetics. She holds a BSc in biochemistry and biotechnology and MPhil in human nutrition and dietetics. And she has earned a PhD in human nutrition from Michigan State University, United States. Is a professional certification to become a dietitian and with the Allied Health Professional Council Ghana. So with this okay, I think there's one interesting thing. She's also a proud recipient of Association of Commonwealth Universities Sustainable Development Goals Grant in 2023. So I request Dr. Mary Amoka to please go ahead with her talk.
Dr. Mary Amoka, can you hear us maybe? Probably the internet is a bit slow.
Okay, I think shall we go ahead with the next?
Yes. Let's move on to the next speaker. Let me show the screen.
Shall we go ahead with the next speaker, or shall we? Some
Yes.
problems. Let us go ahead with the next speaker, Dr.
Yes.
Zainab Al. Shall I go ahead?
Yes.
Okay, now I introduce the next speaker, Dr. Zainab Al Shahid from National Research Center, Egypt. She's an assistant professor in Fingani Ani Fandeniaslu. I hope I'm getting it right. It's King Mongkut's Institute of Technology from Thailand. She's an assistant professor working on infectious diseases and public health consultant with major interest in factors affecting health in low and middle income countries. Her work focuses on sustainable health and LMICs with emphasis on Sustainable Development Goal 3 and analyzes factors affecting population in achieving the SDGs 3 and associated sustainable developmental goals. She's an enthusiastic with various public health issues affecting population in limited resources setting and works to highlight these issues to ensure that no one is left behind and that the equitable and inclusive health is a reality globally. So with this short introduction, I would like Dr. Zainab to please proceed with her talk.
Good evening, Dr. Power. Thank you for the nice presentation.
Dr. Zainab?
Yes. Can you hear me? Can you hear me,
Dr.
Doctor?
Zainab?
Can you hear me?
Yes, we can.
Yeah, is it Dr. Zainab?
Yes, can you hear me?
Yeah, Dr. Zainab.
Thank you, Dr. Power, for your nice presentation.
Yes,
Now
we can hear you, but yes.
I'm going to share my screen. Good evening, everyone. My name is Zainab Abdel Khaliq Al-Shahid. I am a PhD laureate. I am a biochemistry researcher at National Research Center, Egypt. My talk will be about prostate cancer detection, management, and treatment. The outlines of my presentation will be about the disease, how to diagnose, how to analyze the result, how pathology of prostate cancer, treatment, and finally the conclusion. What is prostate cancer? Prostate cancer develops in the prostate. Well, the prostate is a small walnut-shaped gland located behind the bladder and in front of the rectum in men. These tiny glands secrete fluid that mixes with semen, keeping sperm healthy for conception and pregnancy. Prostate cancer is a serious disease. Fortunately, most people with prostate cancer diagnosed before it spreads beyond their prostate gland. Treatment at the early stages eliminate this type of cancer. What are types of prostate cancer? There is only one type of prostate cancer, which is adenocarcinoma. Adenocarcinomas means that it started in the cell of glands. Rarely, prostate cancer can be formed from another types of cells. Less common types of prostate cancer include small cell carcinoma, transitional cell carcinoma, neuroendocrine tumors, and sarcomas. How common is prostate cancer? Prostate cancer considered the second to skin cancer as the most common type of cancer affecting men worldwide. According to the U.S. Center for Disease Control and Prevention, the CDC, for every 100 people, 13 will develop prostate cancer at some point in their life. Most people will live normal lives and eventually die from causes other than prostate cancer, and some will not need treatment. According to the WHO, 1.41 million new cases develop yearly, according to the 2020 scanning, and the number is counting. Approximately 34,100 people die from prostate cancer each year in the US. Causes of prostate cancer. In general, prostate cancer forms when cells divide and never die. In general, prostate cancer forms when cells divide faster than usual. While normal cells eventually die, cancer cells don't. Instead, they multiply, grow into a lump called a tumor. As the cells continue to multiply, part of this tumor can break off and spread to other body parts or metastasize. Likely, prostate cancer usually grows slowly. Most tumors are diagnosed before the cancer has spread. Prostate cancer is highly treatable at this stage. What are the risk factors for prostate cancer? The most common risk factors include age. 60% of prostate cancer patients are above or older than 65 years. Race and ethnicity. Unfortunately, Black or men of African ancestry are at greater risk for unknown reason. Family history of prostate cancer. Genetic factor. The inherited mutated genes associated with breast cancer risk from mothers can lead to breast cancer, BRCA1 and BRCA2 genes specifically. Other potential risk factors include smoking, prostatitis, obesity, or a BMI higher than 30, sexually transmitted infections, and exposure to toxic agent. Diagnosis of prostate cancer. Diagnosis and test. The most important diagnostic tool for prostate cancer is the screening test. The screening test can show whether there is a sign of prostate cancer or that require more testing. Two main types: the digital rectal exam and the prostate specific antigen blood test. The PSA test makes a protein. The prostate gland makes a protein called protein specific antigen. High PSA levels may indicate cancer. Levels low also rise if there is a benign condition such as a benign prostatic hyperplasia or prostatitis. The other diagnostic procedures for prostate cancer include imaging and biopsy imaging like MRI, CT scans, PET scans, or transrectal ultrasound. Also biopsy during needle biopsy by removing a small tissue sample from the tumor and testing for cancer. The biopsy is the only way to diagnose prostate cancer or know for certain how aggressive the case is. The genetic tests also may be performed in the biopsy tissue. Some cancers have characteristics like mutations that make them more likely to respond to specific treatment. The grading of prostate cancer, two main grading is the Gleason score. The Gleason score is an important score that rates how abnormal cancer cells are or prostate cancer cells are. The more abnormal cells, the higher the Gleason score. The Gleason score allows to determine the grade of the cancer or its potential to be aggressive. Staging prostate cancer. Prostate cancer may be local, that means it's within the prostate gland only. Regional, invading nearby structure, or metastasized, that means that it can invade another nearby organs. Prostate cancer may only invade to bones and lymph nodes. Management and treatment. Management and treatment, there are specific procedures and systemic procedures. Specific procedures for management prostate cancer include active surveillance, which means, as we talked before, screening, scans, biopsy, every 1 to 3 years to monitor cancer growth. Surgery include radical prostatectomy, open radical prostatectomy, and robotic radical prostatectomy, which make the use of robotics to make the surgery. Radiation therapy, brachytherapy, and external beam radiation. Cryotherapy by using cold gases to freeze cancer cells in the prostate, eliminating the tumor. And photodynamic therapy, using of medications make cancer cells more sensitive to certain wavelengths of light. Systemic therapy. Systemic therapy include 4 main categories, which first one is the hormone therapy. The hormone testosterone boosts cancer cells growth. Hormone therapy use medication to combat testosterone role in fueling cancer cell growth. The medicines work by preventing testosterone from reaching cancer cells or by reducing testosterone levels. Chemotherapy is the use of chemotherapeutic agent to destroy cancer cells, may be used alone or in combination with radiation if the cancer has spread beyond prostate. Immune therapy by strengthening your immune system, or it's better able to identify and fight cancer cells. Immune therapy is recommended to treat advanced cancer or recurrent cancer disease. Targeted therapy aims to zero the genetic changes or mutations that turn healthy cells into cancer cells to prevent them from growing and multiplying. Targeted therapies that treat prostate cancer destroy cancer cells with BRCA gene mutations. Targeted therapy, that's why I'm going to talk specifically about. Despite the recent advances in prostate cancer treatment, the majority of patients with advanced prostate cancer acquire resistance eventually. Thus, new therapies that target additional pathways are important for inhibiting prostate cancer proliferation and increasing the survival rate. Targeted inhibition of individual kinases of the MAPK and RIPK3 signaling pathways using synthetic compounds represent a promising way to effective anti-cancer therapy. Our object on this study is the targeting of ERK and RIPK3 as a potential therapeutic strategy for prostate cancer by synthetic analogs of a marine alkaloid called aplycinopsin. This study aims to target two important proteins, one targeting the apoptotic pathway. The targeted inhibition of individual kinases of the MAP signaling pathway using synthetic compound is an important apoptotic pathway. The MAP key pathway, or the mitogen activated protein kinase signaling pathway, play an important role in complex cellular programs like proliferation and apoptosis. ERK is, or the extracellular regulated kinase, is a member of the MAPK family and is a major determinant in the control of the diverse cellular processes such as proliferation, survival, differentiation, angiogenesis, and metastasis. This pathway is often upregulated in human tumors and represents an attractive target for the development of anti-cancer drugs. The other pathway is the necrotic pathway. The necrotic pathway of the programmed necrotic cell death is dependent on the kinase cascade consisting of receptor interacting kinases RIPK1 and RIPK3. These proteins are a group of proteins grouped together with the mixed lineage kinase domain-like protein, or MLKL, is a functional RIPK3 substrate that binds to RIPK3 through its kinase-like domain, but lacks kinase activity of its own. RIP3 phosphorylates MLKL at the tyrosine 357 and serine 358 sites. The phosphorylated MLKL forms an oligomer that binds to phosphatidylinositol lipids and chordolipine. This property allows MLKL to move from the cytosol to the plasma and intracellular membrane, which it directly disrupts membrane integrity, resulting in necrotic death. Our method in the study is the synthesis of new aplycinopsin analogs, screening for anti-cancer activity against prostate cancer cell line, in vitro kinase activity assay by ELISA, cell cycle analysis by flow cytometry, and molecular docking study. The screening of the anti-cancer activity against prostate cancer cell line revealed that from 38 compounds, only 7 that showed the high anti-cancer activity, specifically the compound 4E and compound 5E. The activity against the extracellular related kinase and receptor interacting protein kinase revealed that the two main compounds, which are 4E and 5A, showed a diverse activity and inhibitory effect. The cell cycle analysis revealed that the mode of cell death through apoptosis more than necrosis. And the molecular docking study was performed to confirm the interaction of our synthesized compound with the ERK and RIPK3 proteins. Conclusions. Several synthesized aplycinopsin analogs were screened against human prostate cancer cell line. Compound 4B, 4C, 4E, 5A, and 5P were the most active analogs with potent selective cytotoxicity against the BC3 cell line. The induction of apoptosis and cell cycle arrest, which are responsible for cytotoxic activity, were studied for the most active aplycinopsin analogs, although the change in the protein level of the two tested kinases before and after activation may contribute to the mode of cell death by active compound. This dual mechanism of action by apoptosis and cell cycle arrest induction is responsible for the aplycinopsin analog anti-tumor activity. Hence, our newly synthesized analogs are highly promising candidates for further preclinical studies against prostate cancer. Thank you. And any questions? Any questions?
Thank you. There are no questions for now in the question and answer section, but if the audience wants to ask the questions, please, you can ask the questions. I'm referring to audience whenever you want, so we can answer them at the end of the session. I think that we can maybe try again with Dr. Mary Amako, and I will show the slides.
Thank you.
Maybe, yes, Professor Smita Pava, do you want to introduce Dr. Mary Amako?
Yeah.
Okay, thank you.
One second. So there was one question for Dr. Zainab, if I can ask.
Yes, yes, of course.
Yes, I'm ready.
Dr. Zainab, I would like to know, is there any positive control or any known drug that you have tried this molecule against?
Yes, we tried against doxorubicin. It is the most, the main positive control that we used in this study.
Okay, so any in vivo studies that you have taken up other than these in vitro studies? Any in vivo studies that you have taken for this molecule?
No, we haven't. We haven't conducted in vivo study yet. This is an ongoing project. This is the part one. It was a French-Egyptian cooperation. So this is the part one from this ongoing project. Then we are trying, inshallah, to conduct the in vivo study using syngenic model or animal model for cancer, but mainly we use syngenic model as the in vivo animal model with Ehrlich is not successful nowadays.
Okay. Thank you.
Not at all.
So let me introduce Dr. Mary Amoka. She's a lecturer at Guam Nkrumah University of Science and Technology. She's a lecturer and registered dietitian at Department of Biochemistry and Biotechnology. At the same university, she teaches metabolism and health and disease, nutrition throughout the human life cycle, and nutrition in emergencies. And then she holds a BSc in Biochemistry and Biotechnology and an MPhil in Human Nutrition and Dietetics. And she earned a PhD in Human Nutrition from Michigan State University. Her research interests are in improving food security in vulnerable groups while proposing and implementing interventions. She is interested in global nutrition, dietetics, child and maternal nutrition. She's received several honors and awards, including the Borlaug Higher Education in Agriculture Research and Development and Borlaug Leadership Enhancement Achievement Program. She's currently an early career fellow of the Organization of Women in Science in Developing Countries. She was awarded the L'Oreal UNESCO for Women in Science Young Talents Award in 2023, and she's also a proud recipient of Association of Commonwealth Universities Sustainable Development Goals grant in 2023. So I welcome Dr. Mary to present her talk.
Thank you very much, Professor Power, for the nice introduction. I sincerely apologize for the ups and downs and for the distractions of this program. Forgive me. All right, so today we are coming to talk about children. I'm really interested in child nutrition and also nutrition of children, nutrition of people in vulnerable groups. So I'm presenting on food security and nutritional status of infants who are aged 6 to 23 months, born to female headquarters living in Kumasi. So this is my presentation outline, and I'm presenting on introduction up to conclusions. So for the introduction, I live and work in Ghana, Kwame Nkrumah University of Science and Technology. And Ghana is a small country in West Africa, along the coast of West Africa, with a population of about 30 million. And we have 16 administrative districts, or 16 administrative regions. And in Ghana, the infant mortality rate is 32.6 per 1,000 live births, compared to 6 per 1,000 live births in the United States. When you consider child mortality rates, it is 44 deaths per 1,000 live births compared to 7 deaths of these children in a 1,000 live births. If you look at what is happening in the US. So you will know that when you compare what is happening in Ghana and some sub-Saharan African countries, the situation is quite high in Ghana. So headquarters are a vulnerable group in Ghana. And because they are not targeted, they have low income, and they are a workforce who carry loads on their heads for a negotiated fee. So usually when you go to the big markets in the urban areas, you will find these women who will help you carry loads from one point to the other. One thing you realize about these women is that usually they have children and infants strapped at their backs Sometimes it will be their own children, or sometimes it can be children they cater for. But there is one interesting thing you want to know about these women. They earn very little and they have to take care of themselves and their infants. Due to this, it is possible, and due to this, we realize that sometimes they may not even be feeding their children adequately. And we all know that nutrition is a crucial part of health, and proper nutrition is attributed to improved child and maternal health outcomes. Inadequate and inconsistent access to nutritious and safe foods might threaten daily dietary requirements in children. So UNESCO or UNICEF says that there are a number of children in sub-Saharan Africa who are living lives below their physical and intellectual capabilities due to multiple nutrient deficiencies. So when you come to my country, there are a number of surveys, research on child undernutrition, focusing on families and households. But there is little information or no information on these vulnerable groups, because you find them, sometimes they live on the streets, they live on the slums. So when we have to quantify issues happening in families and households, they are neglected. That was what sparked my interest for me to undertake this research. So these are the objectives of the research. 1, to determine nutritional status and food security status of children born to female headquarters. 2, to determine infant and young child feeding variables, as well as assessing nutrient deficiency in dietary. So these are my methods. So because I'm in Kumasi, Kumasi is the second largest city in Ghana, and we have very big markets. So we sampled some of the markets, purposive sampling, Asafo markets, Roma Hill, Edum, Kejetia, and we recruited children between the ages of 6 to 20. Actually, we recruited headquarters with children within the ages of 6 to 23 months. And in all, we recruited 152 of them. Then with the weighing scale and with the height rows that we had, we assessed anthropometric indices, that's weight and height, and we calculated Z-scores using the WHO Anthro software. Then we went ahead to assess food security, dietary assessments, as well as infant young child feeding practices using standardized and approved questionnaires. So these are my results. We realized that majority of the children were within ages of 12 to 23 months. Then most of the mothers were aged between 20 and 29 years. That is about 61.2%. Majority of the mothers, that is 69.1%, had no education. Then you realize that about 49.3% earn less than $10 per week. So this is alarming, because it means that out of the $10, they may have to feed their children, they may have to cater for themselves, and this is not the best. So we know the impact of nutrition on immunity. So we decided to assess morbidity, and we found out that, next slide, please. Thank you. We found out that about 59.2% of the children reported fever within the past week, showing that their immune system may not be optimum. Also, 32.2% of them reported diarrhea in the past 2 weeks. Now we are moving on to nutrition and growth status of the children. We assessed 3 main variables, that is wasting, stunting, and underweight. And we realized that about 31.5% of the children were wasted. That is, they were too thin for their height. And when you compare this to the national statistics, you realize that it is the whole Ghana wasting levels among these children is 10.4, which means that these vulnerable groups are reporting high levels of stunting, of wasting, sorry. When you consider stunting, that is the height of children with respect to their age, you realize that that is also comparable to what we have in the national statistics. Our population had a representation of 18.4. Then underweight, how a child weighs with regards to their age. You realize that that was also high. That is 34.2% when you compare to, please, can you go back? Can you go back? Yes, thank you, I'm still here. Underweight. You find out that underweight was also high. Then what we also found alarming was the food security levels. Food security levels. We found out that 95.4% of the subjects reported very low food security, and only 1.3% of them had high food security. Next slide. So we decided to assess prevalence of nutrient deficiency, because some of these children may be eating, but we are not sure whether the nutrients are adequate or not. So we assessed a few nutrients. When we assessed proteins, can you click for me? It's better if you can do it. If you can click. Thank you. So you realize that for proteins, children within the ages of 6 to 11 months, 30% of them were deficient of proteins in their diet. And when you consider total fat, total fat, children within the ages of 6 to 11 months, 67.4% of them were deficient. And if you look at the roles, fats are important in brain development, among other things. Then we realized that when it comes to calcium, most of the children were deficient in calcium. That is 88.1 for children in the ages of 12 to 23 months, and also 6 to 11 months, 55.8% were deficient. Then iron, that one too, you realize that there are a number of children who were deficient in iron. Next slide. We also realized that there were a number of children who were deficient when it came to minimum dietary diversity. And this minimum dietary diversity actually shows us the micronutrient deficiency among the children. But it's amazing to find out that 84.3% of the mothers had adequate breastfeeding. That is, they practiced exclusive breastfeeding for the first 6 months. Then also, 73% of the mothers had breastfed 1 hour after birth. Then majority of them also had breast hygiene before breastfeeding their infants. Next slide. So in summary, we can say that based on the results that has been presented so far, stunting, underweight, next slide, wasting and food insecurity is high among children aged 6 to 23 months, catered by female head porters. And this presents a major public health challenge that will require urgent action. Next slide. Hence, nutrition education about nutrient intake must be done to improve diets. Then there is also the need for relevant stakeholders to improve the livelihoods of female health porters. I believe when these women are empowered, if they are trained to earn more, it can translate into their purchasing power, and it can improve their lives and that of their children. Also, stakeholders can have something to do with food-based interventions for this vulnerable group. Next slide. And this research tends to impact about 6 of the Sustainable Development Goals. The first one, no poverty. If we're able to improve the livelihoods of these mothers, is going to help improve their lives in terms of poverty. Then also, we are going to improve their diets with food-based interventions. It's also going to improve their health, because once nutrition is improved, it's going to improve immunity, reducing morbidity, and improving the health and well-being of these children. And once children are eating healthy, it's also going to affect their cognition. And when this is achieved, it's also going to impact quality education. When women are empowered, it also helps in the Sustainable Development Goal 5, improving quality education, gender equality. The last goal, and I am with this research calling on all relevant stakeholders so that we can establish relevant partnerships so that we can help these vulnerable people in Ghana, West Africa. Thank you. If you have any questions, I'm here to listen. Thank you.
That was a very nice talk.
Thank
I have one question.
Okay.
So in this potters, have you really associated any sort of a health problem that could be linked to their occupation? I mean, is there something called as an occupational hazard that you come across in these the study population here?
Well, that was not assessed, but it's possible they may have a number of complications. But my focus was on their children. The focus was on the health, on the children. So I didn't ask questions pertaining to the women themselves. Maybe we can do another study that can help us assess occupational hazards to these women. Thanks.
Thank you. So anyone else has any questions for Dr. Mary?
Yes, thank you very much for the wonderful presentation. I wanted to find out from you, is there, like, how much knowledge did the women have? For example, you mentioned that their children, some of them had a fever, some of them had diarrhea. How much information did health information did these women have regarding their health or the health of their children? If you know.
Well, that was also not assessed, but most of these women were not educated. Okay, we found that in the results, about 60% of them were not educated. But one thing you will want to know is that in Africa, some of these knowledge are transferred from our mothers, even in our homes. When you have a fever, your mother has an idea what may be wrong with you. So some of these may be transferred from them from generation to generation. But in terms of scientific knowledge about their health, I doubt. I think it could be very low in the population, though we didn't assess those particular knowledge from the women.
Thank you.
So are there any other questions?
I think there is a question in the question and answer section. The question is on your sample space. I'm just reading it out. Don't you think that space is small compared to the magnitude of the effect when considering West Africa?
Yes. So we use purposive sampling. Yeah, so we had to speak to all the mothers in this age range. So yes, we're expecting to get a sample size of about 250. Okay, for a cross-sectional study with all the parameters. But when we went on the field and we chose all the communities that had these mothers, we realized that these were the people we were able to have. So it was sort of a purposive sampling. So I agree, the sample size is low. And because of this, we cannot make a generalized statement or generalized conclusions with these results. However, this was a purposive sampling and these were what we found on the ground. Thank you.
Thank you. Let me open the program so we can move to to the last speaker for today. Can the moderator present the speaker, please?
I think so we are done with talks. No, we don't have any other speakers, is it? Tanya?
I think we do have Professor Fingani.
But I don't have the bio data that has been given here. It does not mention it. So could you please introduce, because in the biodatas that have been given to the panelists, I don't find the details here. So these are the only speakers that have been enlisted.
There might be some technical mistake. Professor Fingani, would you want to introduce yourself and give your speech, please?
Thank you very much. I think actually Professor Smita had mixed up my part of my bio. She introduced me together with, I think, the previous, no, not Mary, but the previous
okay.
From, yeah. But my name is Pingani Nyasulu, and I'm a research scientist, as well as, I'll just share my slides while I introduce myself. I'm a research scientist, as well as and the lecturer at the Kim Won-Kut's Institute of Technology. So I've done a lot of work on sustainable health and also on infectious disease, and that's what I'm going to present to you today. So my work really is going to look at sustainable health and access to information in low and middle income countries, focusing on Sustainable Development Goal 3. So before I start, the work I'm going to present today is part of my book, Sustainable Health in Low and Middle Income Countries, Achieving SDGs 3s in the Post-Pandemic World. So the work I'm going to talk about today is part of this. And to begin with, it's very important to know that low-income countries are a major player when it comes to infectious diseases globally. They are carrying the heavy burden of infectious diseases, and 85% of the world population lives in low and middle income countries. Listening to the talks throughout this session, it was interesting to notice how much information is missing, how much health information is missing. And I hope this presentation will help us to understand the importance of health information, both in low and middle income countries and in vulnerable populations globally. So the talk I've split into 3 parts. We're going to look at access to information, reaching populations, and timely response. When you think about access to information, we're looking at how much information do the population have, or how much information do countries have or vulnerable populations have. When we talk about reaching populations, who is getting this information? And the information I'm talking about here is health information. And timely response, we're looking at what is the important information that is required for countries, for example, to be able to respond to different disease outbreaks or pandemics. So COVID-19 revealed a lot of gaps globally in health. And we found that there are a lot of gaps in health systems, in governance, in regional and global collaboration, as well as access to information and challenges in strengthening health systems. Many health systems suffered during the COVID-19 because of these 3 things that I'm going to talk about today. So I just put it as art and sustainable health. So art of achieving sustainable health in low and middle income countries. So low and middle income countries, as I mentioned, that they make up 85% of the global population, and 750 million people or adults are illiterate, of which 2/3 are women. So when we look at the burden of diseases that are there in low and middle income countries, we're talking about the SDGs saying that SDG 3, the target 3.3 is to end chronic disease, infectious diseases like HIV, tuberculosis, neglected tropical diseases, waterborne diseases. All these are problems affecting low and middle income countries. So if we have a low literacy rate, for example, for women, and just going back to the previous presentation about women who are not able to read or write, or how are they going to be able to process information regarding health for their children and as well as for themselves?
Sorry, do you show the presentation? Because we see only the first slide.
Oh, maybe I stop sharing first because I'm moving the slides. Sorry about that. Okay, I start again. Sincere apologies for that. Okay. Are you able to see the slides?
Yes, we see the first slide. Maybe just try to move if it works. Slideshow, yes.
Can you see the other slides now?
It's loading. Just one moment.
It's still the first slide.
It's the first slide. But if you maybe move just, if not without slideshow, just if you move step by step, side by side would be also fine, because we will see it.
So you still can see the slides?
We can see only the first slide. We don't see the full screen. We can see first, and then there is on the side, second, third, fourth, fifth.
Oh, okay. Because here it's showing that the slides are showing. Okay, I'll try one more time.
Mm-hmm.
Can you see the slides now?
Yes, yes. We see the slide.
Now,
Sincere apologies.
Yes.
Okay. Can you see me moving the slides? Because now I can't see anything.
No, we don't see. We see the same slide.
it's the second slide, I suppose.
This is
Access to information.
Okay.
You can show the presentation again and just don't do, maybe not showing the full screen.
So I should not show the full screen. Okay.
Yes, we can.
You can see.
One more.
Okay. That are you able to see the slide I'm moving to?
And now when you tap on the second slide. Yes, we see it. It's not the full screen, but we can read it and it's moving.
Okay, so I should not touch anything anymore.
Yes, let's.
Okay.
Okay, thank you.
Sincere apologies for that. So just going back, so the work I'm presenting is part of this third book of sustainable health in low and middle income countries, achieving SDG3s in the post-pandemic world. And the work is looking at, it's going to look at three things. First of all, access to information. Second, reaching populations. And third, timely response. So when we talk about access to information, we're looking at how the population is able to access information. And when we talk about reaching populations, we're talking about how stakeholders are able to reach information, reach populations with health information. And third, we're looking at timely response. With this information, what can the stakeholders do to respond to, for example, disease outbreaks? So as I mentioned earlier, just going back, 85% of the global population lives in low and middle income countries. And at the same time, low and middle income countries are the ones who carry the burden of disease. The major burden of tropical diseases or infectious diseases is in these areas. But also, 750 million adults are not able to read and write. And 2/3 of these are women. So this combination of challenges is something that is going to bring difficulties in achieving SDG 3, especially if we talk about target 3.3, ending these diseases by 2030. So first of all, why is health information important? Health information ensures that there's good health in the population. It enables healthcare personnel and researchers to understand the health needs of their population. At the same time, it allows healthcare systems to plan, implement, as well as build resilient and sustainable healthcare systems that are able to tackle different health challenges within their settings. So earlier I had talked about the target 3.3, ending infectious diseases by 2030. So if the population has this information, if they understand that actually we have a goal to play or a role to play in ending these infectious diseases by 2030, this is going to help them to identify even their own needs that can help them to achieve these goals, and also at the same time enable the healthcare system understand these needs and meet them and implement a sustainable response. So community involvement is very, very crucial and very important if we have to achieve any of the Sustainable Development Goals. And when it comes to Sustainable Development Goal 3, community involvement is crucial, because when you talk about disease prevention and control, we're talking about the communities which are infected by these diseases. If these communities are not able to understand anything about the disease or how this disease is going to affect their health, then it is a non-starter. So we're looking into community involvement at inception of programs. So how much, if we just kind of think about it, how much do the average population understand about Sustainable Development Goals? How much do they know what is required? Do they even know that there's a plan that by 2030 SDG infectious diseases have to be reduced or eliminated or worked on? So community awareness is important, because if the community understands what's happening around them, they can make use of this information and also assist in achieving sustainable development goals, especially all the sustainable development goals. And here I'm talking about SDG 3. So the community role is to understand how to tackle the problems that they have in their setting with the resources that they have within their setting. So if the community is able to work with the stakeholders in their countries or in their settings, they're able to understand what is their role and deal with these infectious diseases. So community access to information, therefore, is very, very important because just going back to the presentation by Anita Bertol, she had mentioned that when she was talking about cancer, she talked about the community not being able to understand, to have the information. And they say that if we had this information before, maybe we could have known how to do things or act in a certain way. So access to information is very, very crucial if communities have to be able to achieve their role in achieving sustainable development goals, as well as if they have to be involved in dealing with the issues of infectious diseases within their communities. So sources of information are very, very important. How do these communities access information? These days we have digital sources and we have non-digital sources. We have the internet, but we can see also the challenges of the internet, even just here in the presentations. I've been following the presentations since yesterday, and you can see that there are communities or people struggling to connect. And that is a challenge or a drawback, because the information that is missed at this point cannot be attained again, because if this presentation is over, then you can't access this information again. So internet is very, very important tool for achieving information. And here we're talking about electronic health. How about mobile phones? Many populations in low and middle income countries, about 96% have mobile phones, even though not all these are smartphones, but at least they can be able to access health information if it is passed on as SMS through them. So all these campaigns can be achieved through mobile phones in trying to prevent infectious diseases. So access to media, access to newspapers, flyers, and billboards, research publications, all these are very crucial for all communities to access electronic health or just any media health information. But media health literacy is a problem. Accessing this information is one thing. How much do they understand? If they don't understand any of this information, then it's not possible for these communities to be able to process this information and make use of it. So I just put a graph here, a small graphic showing how many like estimates of how much of the population is able to read and write, and then how many people or how much of the population is able to understand what is being presented to them with regard to media health information. So when we think about the population which is able to understand scientific information, so we talk about research publications, that is even a smaller proportion. And we know that scientific publications is where all the information about health and achievements in health or new processes or new tools, all these things are published in different publications. But you find that low and middle income countries are still having challenges to access these kind of things, not only because of internet, but also limited access to electricity, because without electricity, they'll not be able to get any connectivity. They'll not be able to have any of their gadgets charged to understand this information. They will have language barriers. We have limited access to technology. So all these things that are gaps that have existed and they're still existing in low and middle income countries. And if sustainable development goals are to be achieved, building resilient infrastructure and manufacturing development of high-tech industries within low and middle income countries would assist in sharing or access to information. So when it comes to scientists or researchers in low and middle income countries, access to scientific information is a problem. And it was a problem in two ways. Previously, many researchers from low and middle income countries could not access publications because they couldn't afford subscriptions to journals or high-end journals that publish most of the work. But then the journals now, they said, okay, we can change this so that we have open access so everybody can access this information. But the challenge was, this opened up another challenge, which was increase in publication fees. So now we have researchers in middle income countries trying to struggle to access, to have their work published because the costs are so expensive. So for example, here I put an example of Ethiopia and Madagascar, where scientists earn between $300 and $500 but a median cost for open access publication is $4,600. And we found that the range of open access publications is between $2,000 and $12,000, which is already a limitation for most researchers in low and middle income countries. So waivers have been there for certain journals, but 3/4 of the journals which are publish quality work do not have waivers. So this is another limitation or a barrier to researchers in low and middle income countries to publish their work or outcomes. So access to health information is a very, very important area also in research and innovation. And this is also an area which is challenging in low and middle income countries. And currently we know that low and middle income countries are struggling to access health information, infrastructure, and tools. And the struggle of access to health information also showed up during the COVID-19, where there was a very, very high increase in malinformation or misinformation, because the information that people could access was not correct, or they could access maybe part of the information, not everything. And in such cases, some information was twisted, some information was not presented accurately. So working on access to information could assist with populations in low and middle income countries getting the right information, getting the correct information that could assist in health, in their health needs and improving their health. So as food for thought, the current state of sustainable development goals shows a lot of fragility in low and middle income countries in the areas of education, gender equality, infrastructure, as well as peace, justice, and institutions. And also SDG 17 as well, partnerships. So if we're going to achieve any of the sustainable development goals, even just SDG 3, we really need SDG 4, SDG 5, 9, and 16, and 17, and also 1. So we need to reduce poverty. We need to have access to education, access to information. We need to have women being able to make decisions on their own, even decisions for their own sexual and reproductive health. We need to have quality infrastructure that can be able to assist in, for example, we talked about the way presentations here about cancer. You find that many people in low middle income countries or many countries cannot actually get cancer treatment, quality cancer treatment that could even save their lives. Some of them have to travel to other countries to attend this kind of treatment. But if someone has no income, especially, and that's a large population in low and middle income countries, then they're left with their plight, with the disease, and also the challenge of people dying from diseases that are preventable just because they couldn't access a vaccine or they had misinformation about vaccines. So access to information is very, very crucial for low and middle income countries. And how do I envision tomorrow for SDG 3, for example? There is need to improve health research. And this is building resilient infrastructure, research labs, training centers to improve like knowledge and capacity building for researchers and other scientists, as well as peace, which is the most important thing, as if anything has to be achieved, because without peace, then none of the SDGs would really be able to be achieved. And as I mentioned earlier, 85% of the world's population lives in low and middle income countries. So if there's no peace in low and middle income countries, that'll be a very big challenge to attain not only SDG 3, but also the other sustainable development goals. Thank you very much. If there are any questions, I'll be happy to take them.
That was a wonderful talk. And apologies from my side, because I think after Zainab's name, I think directly, she has not given her bio, but your bio starts off. So let me introduce you again. This is Assistant Professor Fingani Annie Nyaslu, right?
Yes,
from Ken Mongat's Institute of Technology, Thailand. Fingani is Assistant Professor in Infectious Diseases and Public Health Consultant with major interest in factors affecting health in low and middle income countries. Fingani's work focuses on sustainable health and LMIC with emphasis on sustainable development goals and analysis factors affecting population in achieving the SDG 3 and associated sustainable development goals. Her work highlights the impact of various shocks on health and lifestyles, determinants of health, as well as socio and economic outcomes in rural population, as well as the vulnerable populations and limited resources. She has authored 3 books. Her first book, that is Infectious Diseases and Rural Livelihood in Developing Countries and Causes and Impact. She has a very elaborate biography. So I'll just cut it short. She holds a PhD in infection biology from Carolina Institute, Stockholm, Sweden, and a Master's of Science and Applied Microbiology from University of Botswana and Bachelor's of Science from University of Malawi. And she is currently working as the Assistant Professor at the Faculty of Medicine, King Mongo's Institute of Technology. And she is very proficient and fluent with English, French, as well as 4 of her native languages. That's incredible. And I think Fingani is the very apt speaker for the whole panel, where the whole conference has been focused on SDGs. So it was wonderful listening to you. So if there are any questions for Fingani?
Thank you. There are no new questions in the question and answer section. And we would have to finish the conference in around 3 minutes because we are running out of time. So if there are anything you would like to say. Okay. Probably something with the internet. Yes, of course we can. Dr. Zainab, I'm sorry if there was some mistake with the CV. Maybe it was on our side, so I sincerely apologize for any of this. Anyway, it was really nice to have this nice conference. If you want to have the group photo, let's have the group photo. All the sessions will be uploaded on Facebook because they were all recorded. Yes. And if there are questions.
Thank you, Anita. Thank you, Anita. Nice meeting you. Nice meeting you, Dr. Fingani. Sorry for the inconvenience. It's not my mistake. And nice meeting you. Hope to see you in another meeting, inshallah.
Hopefully. Thank you very much. And thank you all for the wonderful presentations. And thank you, Tanya.
Thank you for nice presentation. Thank you. Thank you, Dr. Pawar. Thank you, everyone. Thank you, Anita.
It's always better to meet in physical rather than online mode.
Inshallah. Thank you.
Maybe next time we could meet each other in some other platform.
Inshallah.
So I
Thank you very
thank,
much, Professor Smita, for the
so let
great
me thank the
moderation.
organizers for giving me this opportunity to chair the session. And it was wonderful interacting with all you participants, and it was very wonderful to listen to your talks. So hope in future that we could meet again in physical mode. So Tanya, can we end this session now?
Yes, we can end the session now.
Any details that you would like to give them about the certificates or anything that they're supposed to receive for the talks?
It will be following with the emails in the next days. Everything you will receive. For now, this is from me no information. But you will be receiving the emails.
Okay, right. Thank you. Sure. So thank you.
Thank you.
Shall I end the session? Thank you.
Okay.
Good day.
Good evening.